Hello everybody, my name's Michael Hunix here with Solheim Enterprises, and today I'm going to teach you guys how to master the ventilator. It's not as scary as it sounds, and I promise you I will break it down section by section, setting by setting, so you'll be able to feel comfortable setting the ventilator on your newly intubated patient. Kind of as an overview here, what are we going to talk about in this lecture? We're going to discuss indications for intubation. We're going to go over specifically definitions relating to each setting on the ventilator. We're going to go over ABGs, different modes of ventilation, and we'll wrap it up here with some case studies. Okay, let's jump into this. Indications for intubation. Our intubated patients had trouble doing one of two things or even both, oxygenating or ventilating. Common reasons why: sepsis, trauma, even ARDS, pneumonia, asthma. All of these diagnoses can lead to difficulty with oxygenation and ventilation, causing them to be intubated. If we look at this diagram over here, we're going to see a ventilator, and we look at it and we're so confused. What does all of this mean? What are the proper settings? What is it going to control? Where do I even start? No worries, we'll break it all down definition by definition, and we'll get through it. Let's get started with our first definition, that being tidal volume. Tidal volume is going to be the amount of air in mLs that is installed into the lungs. The equation that I want you guys to use for this is a lung protective strategy, and that's going to be 6 mLs per kg. When we're figuring out their weight in kilograms, we want to make sure that we use their ideal body weight, not what their actual weight in kilograms is at the time that you are taking care of that patient. For males, to figure out an ideal body weight, we're going to use the equation 50 plus 2.3 times their height in inches minus 60. And for females, we're going to use the equation 45.5 plus 2.3 times their height in inches minus 60. And that's going to give us in kilograms their ideal body weight that we'll be able to then plug into our original equation of 6 mLs per kg. And this is going to be the starting point for your patient and a way for you to know exactly what number to plug into the ventilator when you're setting their tidal volume. Now that we have our starting point of tidal volume, we need to know now what is that going to do if I increase that volume or decrease that volume. An indication for increasing that tidal volume is if our CO2 was too high. Because what do we want to do? Take a larger breath in, so we take a larger breath out. Every time that we exhale, we're exhaling more CO2. So the larger volume you inhale, the larger volume you exhale, and that is going to drop your CO2. If maybe that initial setting is dropping your CO2 too much and now we need to increase that number, we're just going to decrease the volume that we're putting into the lungs. So if our CO2 is too low, we can decrease our tidal volume. That then will be a smaller breath that we're taking and a smaller breath then that we're exhaling. If we're exhaling less CO2, then that means that we'll have more CO2 within our body. Now that we've got our tidal volume figured out, let's move on to respiratory rate. And you guessed it, just like tidal volume, we're going to be manipulating our CO2 with whether we increase or decrease our respiratory rate. So if we increase our respiratory rate, we're going to do what? We're going to blow off more CO2. And then the exact opposite of that, if we decrease our respiratory rate, how many breaths that we're taking in a minute, we're going to do what to our CO2? If we decrease the times that we're taking a breath, what's going to happen? Our CO2 then is going to rise because we're blowing off less volume in a minute. Our next setting, inspiratory pressure. When we're setting our inspiratory pressure, that's going to be the initial pressure that we're giving and delivering to our patients that then ultimately is going to give us a tidal volume. And now that we understand the role of a tidal volume, if we increase our inspiratory pressure, that's subsequently going to increase our tidal volume. But if we decrease our inspiratory pressure, that's going to, you got it, decrease our tidal volumes as well. And just like the slide before, if we increase our tidal volume, we're going to blow off more CO2. If we decrease our tidal volume, we're going to hold on to more CO2 because less of a volume is being blown off. The next setting that we're going to talk about is inspiratory time, and that's going to be the time that you set the ventilator to deliver a breath in seconds. If we increase our inspiratory time, we're going to increase our PaO2 and CO2, and if we decrease our inspiratory time, we're going to decrease our PaO2 and CO2. And where that comes into play is setting our inspiratory to expiratory ratio. You're not going to necessarily manipulate this number. How you're going to manipulate it is by increasing or decreasing the inspiratory time. Physiologically, you and I right now are spending twice as long exhaling as we are inhaling. And if you just take a couple seconds to just sit there and take a breath in and then you take a breath out, you might not have even realized that you are breathing out or expiring longer than you're taking a breath in. But for different reasons, if patients were having difficulty oxygenating and you increase their inspiratory time for that breath, you're going to bring that ratio of inspiration to expiration closer together. So what that's going to do is you're going to inspire, hold that breath in longer, allowing for more oxygen to diffuse across those alveolar units before you're exhaling. But if you're inhaling in that respiratory cycle longer than you're exhaling, you're bringing those two times closer together, then you're going to subsequently increase your CO2, because if you're exhaling for a shorter period of time, then that gives you less time to blow off CO2, which is why increasing your inspiratory time not only increases your PaO2, but also increases your CO2. And for some patients, we even will inverse the I to E, inspiratory-expiratory ratio, because they are having such difficulty oxygenating that we're going to inhale for twice as long as we do exhale. And then we take another breath in, exhale, take another breath in, and that's all allowing for more oxygen to stay in those alveolar units to hopefully diffuse across to systemic circulation. But we're also watching out, again, we're decreasing that expiratory time, so what's that going to do? Really be increasing our patient's CO2. But that's where we walk the balance of how are we going to manipulate this ventilator to the specific needs of the patient. And when in my practice, when we inverse that I to E ratio is going to be for our patients who are in ARDS. Okay, let's move on to PEEP. PEEP stands for peak end expiratory pressure. When we're setting our PEEP, that's going to be at end expiration. What pressure is the ventilator going to be delivering to keep those alveolar units open? So by the time that your patient takes the next breath, they're already open, they did not collapse, and the breath will be able to get in fully to the every part of the lungs to be able to then be ready to catch that oxygen to diffuse across that alveolar unit. At a minimum, for our ventilated patients, we're going to have our PEEP set to 5. But if we were having trouble with oxygenating our patients, our PaO2 was low, we're going to increase that PEEP. The more PEEP that we have on, that at the end of a breath is going to be priming our lungs more and giving the lungs more force so those alveolar units do not close. What we have to be very conscious of, though, is as we're increasing that PEEP, that peak end expiratory pressure, that's increasing the intrathoracic volume and pressure within our chest. As those pressures rise, we might see our patient's blood pressure decrease because externally, that extra pressure that's on the heart from the lungs is going to be tamponading the heart externally, much like it would in a pericardial tamponade situation, but the patients don't have it at this point. We're externally doing that from the lungs by increasing our PEEP so much. So be very careful as you're increasing your patient's PEEP to what is the hemodynamic effects that it's having on our patients. Are they still maintaining an adequate blood pressure? All right. Much like our PEEP is going to help increase our PaO2, setting our FiO2 is also going to help us raise our PaO2 as well. Initially, your patients are going to be hypoxic, and your first FiO2 that you're going to set them to is going to be 100%. Once you get your second ABG, you're going to see that number be well over the normal limit of 100, and that's going to signify to you that you're going to be able to come down on your FiO2. The goal here is going to be able to get our FiO2 down to 40 and just making sure that every ABG that we're getting, as long as our PaO2 is in that 80 to 100 range, then we can continue to dial it down. And the minimum setting that we'll set it to will be that 40%. Initially start out as 100, and then as we get our results back and our PaO2 is always between 80 and 100, we'll get it down to that lowest amount that we're going to want to deliver of being that 40%. Now that we know how to set up our ventilator and all those definitions, let's work on our ABGs. First, let's talk about pH. pH is going to be representative of our acid-base balance. Normal pH, 7.35 to 7.45. The more acidic our patient is, the lower of a pH that they will have, and the more alkalotic our patient is the higher that our pH will be. When we're talking about CO2, we're talking about acid. The higher our CO2 is going to be the more acidotic our patient is, and then the lower our CO2 is going to be, or help our patient be, more alkalotic. PaO2 is going to represent our oxygenation, and our bicarb is going to represent that base balance, is going to be, and think, metabolic. And think of the kidneys, because bicarb is produced from the kidneys. So the lower that our bicarb is going to be one of two things. Our patient is compensating for an acidosis, or we're having complete failure of the renal system. If we look here to the chart, a normal pH, like I had mentioned, is 7.35 to 7.45. A normal CO2 is between 35 and 45, and if you ever have trouble remembering that, just think of what a normal pH is. And those last two numbers there are going to be the same then there of your CO2's normal range, that 35 to 45. We want our PaO2s to be between 80 and 100, and a normal bicarb is going to be between 22 and 26. Now, let's put it all together. We know our definitions to set up the ventilator, and we now know the normal values of an ABG. So let's take a look at if we want to increase our CO2. What do we want to decrease on the ventilator? We want to decrease their respiratory rate. We want to decrease their tidal volume. And if we were setting our inspiratory pressure, we want to decrease that because that'll allow us to have a lower tidal volume delivered. Now let's say that our CO2 is too high and we want to decrease that. So what do we want to do? We want to do the exact opposite. We want to increase our respiratory rate. So every time that we breathe in a minute, we're blowing off more volume. We also can increase our tidal volume because the more volume we take in, the more volume that we're breathing out. The more volume we breathe out, the more CO2 that comes out with it. And just like before, if we increase our inspiratory pressure, that's going to increase our tidal volume. And if we increase our tidal volume, you're going to again breathe off more CO2. Now, on the other hand of things, if we wanted to increase our PaO2, what are we going to do? We're going to increase our PEEP, we're going to increase our FiO2, and we can also increase our inspiratory time. If we want to decrease our PaO2, we can decrease our inspiratory time, we can decrease our PEEP, and decrease our FiO2. Next step here is to choose a mode of ventilation. What are your options? Assist control, volume control, assist control, pressure control, SIMV, or synchronized intermittent mandatory ventilation, or pressure support ventilation. We're not going to talk about SIMV and pressure support ventilation within this video because we're talking about just intubating our patients and they're going to need full support. So we're going to either choose assist control, volume control, or assist control, pressure control. Both of these modes of ventilation are going to deliver the specific settings that we talked about. The major difference between the two is that in volume control, you're going to preset the volume that every breath that you have it set to, they're going to get that set volume. And if they take a breath over the specific respiratory rate that you set the ventilator to, they're also going to be delivered that volume. In pressure control, you're going to set a pressure that's going to allow you to have an adequate tidal volume. And the same, just like volume control, if they initiate that breath, then that is going to be a fully supported breath as well. Some initial basic vent settings, and again, all of these are going to be patient dependent. But if we initially were setting assist control, volume control, we can set our respiratory rate to give or take around 16 breaths per minute. We're going to use our lung protective strategy of 6 mLs per kg of ideal body weight. We're going to set our PEEP anywhere between 5 to 10, and we're going to initially set our FiO2 to 100. If we were going to use assist control, pressure control, our respiratory rate, again, we can set around 16. Our initial inspiratory pressure, we can set to 20. But we want to watch very closely at that pressure. How compliant are their lungs? Are you overinflating their lungs or not giving them enough support? You can go back and figure out, well, how much of a tidal volume should I be giving these patients? And use that equation of 6 mLs per kg to know what your goal tidal volume target is going to be. Your inspiratory time set to 1 second, PEEP anywhere between 5 to 10 again, and with that initial FiO2, keep that at 100. Let's put it all together here and do some case studies. Here we have a patient that's ABG is 7.19, 52, 80, and 22. Your current mode of ventilation is assist control, pressure control. And looking back at that ABG, what is wrong with it? We notice our patient to be acidotic with a pH of 7.19. Why are they acidotic? Their CO2 is 52, which is outside of our normal range of 35 to 45. So in pressure control, how are we going to lower our patient's CO2? We're going to increase their respiratory rate, or we can increase their inspiratory pressure. That's going to do what? Increase their tidal volume. When you're making these changes, I would choose one and see if that works before you're making 2 changes at the same time. But both of those changes will lower the patient's CO2 and will hopefully correct their acidosis. Good job. Let's move on to the next one. This ABG, 7.40, 40, 55, and 15. This patient's in assist control, volume control. And as you're looking at it, what is wrong with this ABG? They're hypoxic. Their PaO2 is 55. In volume control, how are you going to increase their PaO2? One of two ways initially, right? You're going to increase their FiO2, or you could increase their PEEP. Make one change at a time and then repeat that ABG to see if you get the intended effect that you wanted. What I would say though is that if your patient is requiring more and more FiO2, really try and manipulate that PEEP to see if that's what they need. They need more pressure to keep their alveolar units open, and see then if you can come down on your FiO2. All right, guys, last case here. It looks like it might be game over for this patient, but now with all of your knowledge, you're going to be able to fix them. Let's look at their ABG. 7.05, 60, 50, and 15. Do they have any normal values there? No. This patient is severely acidotic due to their CO2 being elevated at 60. They are also hypoxic with the PaO2 of 55, and their bicarb is also low at 15. Your body, from a metabolic bicarb standpoint, is trying to compensate and bring up that pH. What else might be going on with this patient? That their metabolic status or their use of their bicarb is so much to be able to compensate. These patients might have a metabolic process going on as well. They might have pneumonia that is impeding their oxygenation and ventilation. And on a metabolic side of things, they're floridly septic. So their kidneys might not be able to buffer as well. And when we now choose a mode of ventilation, we know that we're going to give full support to this patient. So we're going to choose assist control, volume control, assist control, pressure control. I found in my own practice that patients synchronize better to the ventilator on a pressure control setting. Looking at that ABG, how are we going to manipulate it? We're going to make sure that our FiO2 starts out at 100. Our PEEP is going to be a little bit higher than 10 to make sure our alveolar units are open. We're going to increase that respiratory rate. And we're also going to make sure that as we increase our respiratory rate, that we still initially though start at that lung protective strategy of having that 6 mLs per kg. After some time, we're going to draw another ABG and see how those initial settings work and continue to tweak those based on what that end result is. I know that that was a ton of information for you. Feel free to rewind this video, rewatch this video, and practice this and take this to the bedside. The more you use these terms, become more familiar with the equipment, the more comfortable you'll feel with setting up the ventilator. Again, my name is Michael Hunix, and I hope you found this video educational.